Welcome to Care Transitions Today, Case by Case, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we take a fresh look at the real-world challenges of case management related to care coordination, patient transitions, utilization management, and complex discharge planning. Today, we are joined by Dr. Rebecca Severe and Dr. Sweta Singh. Dr. Rebecca Severe is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Whether you're a physician, case manager, or leader in case management, this season provides valuable insights to navigate complex patient transitions. This is Care Transitions Today, Case by Case. Let's begin the discussion with our first case.
I've got a case I was hoping that I could get your perspective on. I know with you working at a larger academic medical center, I was hoping that you might have some advice on a case that I encountered that it was a first for me. You know, I've been doing this a while, and I was covering some frontline reviews the other week, and this was a new one for me. So I thought I'd get your spin on how you would manage a similar case. So the patient that I have, it's a traditional Medicare patient, 80-year-old female, has a history of congestive heart failure with a reduced ejection fraction of about 20%. Had a history of AFib, mild pulmonary hypertension, some moderate tricuspid valve regurgitation, and severe functional mitral valve regurgitation. And this particular patient was having, they had tried to optimize her cardiac meds. They even had discussion about, LVAD, and ultimately the decision was made to see if addressing her mitral valve might provide her some relief with this persistent dyspnea and exertion and provide better quality of life for her. So this patient, one of our facilities is enrolled in a trial involving one of these valve devices. Now, the particular CPT code for this particular device is 0345T, which, I had to look up. I usually look up. I don't know all these codes off the top of my head, but as I was looking at the case, I took a look at it. It is on our inpatient-only list. So when I was looking at this case, what I stumbled upon that was a little bit different for me is that the patient, being part of a trial, came as a blinded trial. And so the patient came in, and as I was looking at the case, it ended up being a 1 midnight stay. And so the UM nurse sent it to me and asked, should this be a code 44 before this patient discharges? So I'm going to pause there and just see, what your thoughts are, how you would manage it, knowing, the information I gave you.
So one more time, can you the procedure, that CPT code, can you repeat back the procedure?
It's 0345T. That's a transcatheter mitral valve repair percutaneous approach via the coronary sinus.
It's so couple thoughts. One is it's an inpatient-only surgery. So this procedure otherwise won't be able to bill. And I think inpatient sounds appropriate. I've run into, I would not say a similar case scenario, but where patient had a TAVR or needed a TAVR, but the indication for it was something that wasn't listed in the original CMS guidelines. But it did say that if there are some approved clinical trials that if we are using TAVR for that purpose, then it could be approved. And having said that, so it wasn't a traditional Medicare, it was Medicare Advantage. So I was able to discuss, hey, clinically, there is no alternative for the patient. The surgery is absolutely needed, and this surgery does not make sense to be done as an OIB. It's an inpatient only. So we were able to discuss. So from my initial thought is, this is an inpatient only procedure. I would keep it inpatient rather than doing code 44. The interesting part definitely is the trial or study. So that's where it gets a little bit like, what was the terms of the study? What does the guideline say? I would not say a similar, but a different case scenario we've run into is where as part of the study contract, we've been able to discuss, because a lot of time we run into issues where payer would not pay for patients getting admitted for the study drugs, especially with the immunotherapy or chemotherapies, and then the care after that. So they want study to be paying for it. So we try having that in the clause, like if this patient gets this study or we part of the study gets this chemotherapy admission for continuous neuromonitoring and so on, CRS monitoring, then it's covered by the study. So I'm curious on how did you guys handle and what was your take on it?
Yeah, so a couple of things that I stumbled upon it. So first, when I was digging into the case, when I dealing with a procedural case, I go to the op note. I go there to like see what was done or not done. Well, that was the first interesting part for me on this one is because the study is blinded. So the study is designed so that some patients actually get the procedure and some don't. But they do undergo a left and right heart cath. And some of those patients in that process are going to have the actual inpatient only procedure and some will not. And the op knows because it's blinded, they don't tell you exactly if it was done or not. So that was the first thing I discovered. So that's where initially I thought this was easy. I was like, oh, it's an inpatient only, right? Should be inpatient. What's the question? Well, the question became, did the actual inpatient only procedure happen? So that was the first thing. So I tried my best, reached out to the clinical team, and they're like, it's blinded. We are not going to tell you. So that was new for me. I've never encountered that. The second was, as you mentioned, this was happened on a weekend that I was looking at the case, so I couldn't reach out to a study coordinator, et cetera. So I had to make a game time decision, which was, I'm keeping it inpatient. I'm concerned it was an inpatient only. You're right. You asked a great question. And I think, if you, our listeners are encountering these at their sites too, who is paying for it? Because I think that's an interesting point for me that I kind of went back and forth with my team on. And for this particular study, it is being paid by the study. Now, it for this particular study, it can be billed out to Medicare. Medicare is right now the only payer that will pay for it if you meet their criteria for it. So it's possible to bill it to Medicare, but for this particular study structure that we've got, it goes to the device company as part of the study grant that's going on. But so I thought, okay, does that make it easier or hard for me if I don't have to think that it's traditional Medicare? So I opted to follow traditional Medicare rules for this case. I'd like to get your thoughts on that logic that I applied to it. And I can, I'll go into why I ended up holding true to traditional Medicare versus just saying, well, it was a short stay. It doesn't matter. It's a device study. We can just do whatever. I mean, what are your thoughts on that? Knowing that it's traditional Medicare is a normal payer, but because of the study, it is going to go to the device company and be part of a trial.
I would still follow the traditional Medicare rule and agree with your approach in terms of keeping it inpatient as there was an intent or initial possibility of inpatient-only procedure. Now, the tricky part definitely comes as that we are blinded. We don't know if that procedure happened or not. And in terms of, so was this built to study or was it built to CMS?
It was billed to the study for this particular case, and it was an overnight stay. It is possible this patient had the inpatient-only procedure done. There, as part of the study, they will do some initial testing, and some patients will get weeded out. This particular patient met the criteria and were definitely eligible. So any patient that's eligible, whether they have a sham procedure or the actual inpatient-only procedure, stays overnight for the appropriate monitoring. So this patient fell into that category. If I think for me, if it would have been she got ruled out and went home a couple hours later, then I would have been very comfortable. Just it was an outpatient billing, no matter who the billing was going to. But so I don't know if that helps you a little bit on your thinking around the case.
Yeah, no, that's definitely helpful. And in terms of again around this case, I would follow the Medicare rules, primarily because there is still a possibility this patient did undergo an inpatient-only surgery. There was definitely an intent for an inpatient-only surgery. Now, procedure started, initial insertion of the needle happened, and so on, things happened. Now, did the procedure happen or not? We do not know at this point. Patient had a post-op monitoring like it would be done for procedure that happened. So did get all the appropriate care as well. And this was built to the study, so it's not even, so that reduces the potential risk of if the patient did not have the surgery. And that's where I think the contracting around the study is very important. I'm like I was sharing before in our institution, because we also do a lot of clinical trials, and we run into issues with sometimes payer not agreeing and so on. So we started being more proactive. Some of these newer therapies that needed moderate level care for a while after they get that medication, like as part of REMS or CRS monitoring, neurotoxicity monitoring. One of the studies said, that's fine if we have to pay for the hospital stay and that peers are not paying, but we'll pay it as an OBS or as an OIB. So we pushed back saying that's totally reasonable if they're getting discharged within 48 hours and they're getting admitted only for 48 hours, no complication. But if complication happens and they end up staying longer, or we are managing now neurotoxicity, CRS toxicity, then we would like it to be inpatient. And that's where then, with the help of contracting, with the study and a lot of our major peers, we came to, okay, at that point, if complication happens and it's more of a medical care now happening, then it can be billed to the payers, to the insurance company, and that it's appropriate as an inpatient. But if it's a routine care, no complication, and just the monitoring, the study drug, and that stays covered by the study.
No, I think that makes sense, especially when you're not in the territory of the inpatient only, and maybe you're not dealing with a Medicare patient. I guess where I went with my logic when I was trying to do the right thing for the patient, trying to be compliant in all of this, was that if this was an inpatient only, and let's just say this particular patient had complications and maybe it went into a more complex stay, what I was worried about is that maybe some of the care, both in the hospital, or if it was a more prolonged stay, and let's say this patient got debilitated because of complications and needed access to their skilled nursing facility benefits, that we would need to make sure we follow traditional Medicare rules so that we did not, deny a Medicare beneficiary access to, that skilled benefit. I also wanted to make sure that if there were any Medicare notices that needed to go to this patient, that they went in a compliant fashion. If this were, if they were Medicare, we would treat them this way and they would need to get this notice. I didn't want to treat them differently, knowing that maybe the bill was going to go to the study and not Medicare. I didn't want to have a double standard. So I guess that was where I went with my logic in trying to be compliant and fair, and just thinking about all the different ways that the case could go. So anyway, it was just a new one for me, and I, just thought it was worthwhile to kind of talk through and get some other opinions on. So.
Absolutely. And that makes total sense, especially because we're not just now talking about one case. We're talking about what about the future cases with similar getting admitted. And you rightly said, this one was discharged in one midnight, but what if there is a complication and patient ends up staying longer? And now if we don't start right patient class from the get-go, we would be jeopardizing the patient's ability to access their benefits that are very appropriate. That's a good point, Rebecca.
Well, I think that's what we had on that case. I don't, Sweta, I think you had a case you were hoping to talk about today too.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. APPLCOM is inclusive of all practice settings. Membership in APPLCOM also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, APPLCOM membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers, join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org/membership to learn more.
Yeah, I have a surgical case that I was hoping to talk about. And this one is 60-year-old who got admitted after the surgery. So patient underwent 25 centimeter thigh mass removal all the way to the IT band, and was admitted, say, on January 21st. And he was it was a pretty large surgery to begin with, but all the codes were still OIB codes only. Outpatient in bed, we had the authorization for the OIB as well. And patient was still in hospital and was reviewed on day 3 by our PA group. Now, there are no complications. Everything's going as expected post-op. But there are 2 drains in place and getting IV antibiotics during this time as part of perioperative care. And if ready to be discharged, can be switched to oral. But the reason patient was still in hospital is, one, needs subacute rehab. And I mean, the notes, obviously, surgery notes, as you know, how they can be. Everything's looking like moving in right direction.
Yeah.
Patients eating, feeding, Foley's out. And now it took us a while to figure out, but what I could tell is that patient's still in hospital is because 1, failed PT, 2, has drain output pretty significant, and 3 is on IV antibiotics. Now you're reviewing this case. Would you keep it OIB or would you flip it to inpatient now?
I don't recall if you said what the payer is, but I think I would answer the
It's
same way.
midnight care. It's a Medicare Advantage.
Okay. But I think even if I was dealing with, Medicaid commercial, I think my answer to you is going to be the same because my logic is the same for why I'm going to make a recommendation. I agree that we're seeing a lot of our payers up front when we have a planned procedure. If it's not an inpatient only payer, an inpatient only list payer, but if they are, they will not upfront approve anything for inpatient unless it is on that inpatient only list. So I'm not surprised by that, but that doesn't mean they won't pay it post-operatively depending on the course. So that's where, and I oftentimes have to coach our UM team to not be like, well, it's not inpatient only, we can't make it inpatient. No. We still think about if it's a 2-midnight, payer, we need to look at that. Even though they're surgical and it's planned, are they having medical necessity for that second midnight? You hit on some good points. I definitely think if they've still got drains in, I will look at the output. I think that's a good, pearl to take away if you're a physician advisor or UM nurse, to take a look at drain output. And if they're high, and sometimes, I'm not a surgeon. And so sometimes when I'm looking at a case and I see drains and I see a certain amount, and if it's not like 5 cc's or 10 cc, I will intentionally reach out to the surgical team and ask them about this. Is this part of why you need to keep the patient here? Because as you mentioned, it may not always be called out, but it's definitely part of the decision making from that surgical team. So I will look for drain output. I have been finding, I know sometimes you feel like as PAs, and I know some of my PAs will come back and be like, oh, they're just here for placement. Well, placement for someone who's been in just a functional decline over time and they should have went to the nursing home a long time ago is different than someone that comes in with an acute illness and has a significant functional decline that just happened over a period of days. So I have been finding that a lot of my payers, especially that Medicare Advantage payers, that functional decline, and taking a look at your PT notes that say patient was independent before, now we have objective things like an unpack score of 12. They were able to walk 4 feet before they had excruciating pain and they required moderate assist or whatever. Look at those details of your therapy notes. I think sometimes they can be hard to read. I think we're not therapists. And so I know as a hospitalist, I wasn't used to reading until I became a physician advisor. So I think the therapy notes can be a gold mine too. And if you can give an objective argument as to why they need skilled therapy, especially in the hospital, and it's a risk, their mobility impairment risk compromising their surgical site, I think you can make a case. So I would go for inpatient for this. And if I had to do a denial argument, peer-to-peer argument, I would focus on the drain output and I would do your debility issues as well. And I would find out the antibiotic, like why the antibiotic, are they just not switching it? Or is there something concerning? Maybe they didn't call attention. Maybe there's some redness that they're worried about. So I don't know, where did you go with this?
So I totally agree, and you hit it on the nail. Like you were spot on. Key points that were, so this case, we went with inpatient too, primarily because one was the high drain output. On talking to the bedside provider, the reason patient is still in hospital is because the drain output is too much. Because a lot of times when I run into these cases and I'm doing peer-to-peer, like I agree, I would take this even if it's denied to the highest level of appeal. And they would be like, oh, patient can be discharged with drains at home. And I totally agree. We discharge them all the time, but not when they have 100 cc of output coming every 4 to 6 hours. So it has to be a reasonable output, at least that's more safer. And the rationale for IV antibiotic was till the output reduces enough. And third, like you said, in terms of, it's not just a placement, because a lot of time Medicare Advantage don't need inpatient to be covering for SNF and SAR. So they would make that argument too. Oh, we can cover SNF SAR, or we can approve that. And this patient, if is safe to be discharged, just discharge it to SNF and SAR. yes, we do want that approval. Yes, that's an impacting factor. But at the same time, we need to be able to get them to be rehabable goal or be able to get them to sniff. So their pain control has to be decent enough so they can work with PT. The last point I wanted to make is the extent of the surgery and the location. So this was a 25 centimeter thigh mass, not like a 5 centimeter.
Yeah,
It's a big incision, big mass, and that does debilitate significantly. And that was one of the arguments that we made during the discussion. And like you rightly said, these surgeries, when you know from the get-go, it's a huge surgery, or it will be a decent length of stay post-operatively, even though pre-certification team has repeatedly tried to get the approval. A lot of times we do not get an approval, like you said, from the peers for an inpatient pre-operatively unless something is just inpatient only. So it's not uncommon, but like you rightly said, and was the key point, if it's not an inpatient only, there is no complication happening per se. It's an expected post-op, but this is an expected post-op care. At the same time, it's not your just nausea, vomiting, or some pain after a surgery that still can be managed within 48 hours and discharged. It's still a complex care, and that needs a hospital-based setting and inpatient. That's why we went with inpatient, and we were able to get this overturned.
Good. Yeah, no, and I think that seems very appropriate, and I would hope that would have been the outcome for you. I know sometimes it isn't, but it definitely, I would have agreed with you too, that I would have taken it, if I would have not been able to return it into peer-to-peer, would have asked my, post-claim appeals team to continue our ongoing appeals process for it. So great. Another interesting case. So thank you for sharing that.
Thanks for bringing that case with the study. And that was interesting too. And something being prepared ahead of time helps.
Yeah, definitely with that one where, it was a good learning and teaching case for us and will help us with the next one. So great.
Thank you.
Thank you to everyone for joining us for another episode of Case by Case. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so that you are notified when we upload new episodes. Until next time, this was Care Transitions Today, Case by Case.